All right, welcome back to the podcast. I am joined today with Dr. Fred Penzel. He is an OCD expert who has been on my podcast before. He specialized in OCD um, about 40 years ago, I think. I remember you telling me when a professor
43
said it
now.
was 43, when a professor said it was too hard to treat. And you had this kind of gumption, you know what, I'm going to try to figure this out and try to treat it. And I've appreciated corresponding with you and hearing some of your wisdom. And I thought I would have you back and really focus in on one specific aspect of OCD, which is kind of the doubt and the need for certainty. And I've had a couple of these patients that it seems almost like there's a pure aspect of it where then they almost like develop more doubt about the treatment, or like doubt about the doubt. So I wanted to get your take on this and move the
Sure.
dialogue.
I think it's useful to note that in the 19th century, OCD was referred to as the doubting sickness or the doubting disease. And I think even back then they recognized, what one of the central features of it was actually doubt and guilt actually are two of the main features that you see in OCD. But the doubt is crushing really, and it can apply to anything. Basically, it seems for some reason, which we still don't understand, to attach itself to whatever bothers a person the most, or whatever gets their attention most easily. Maybe it's just that people think a lot of things, and only certain things stick because they really are matters of concern to that particular person. But yeah, doubt is, and it's a doubt that cannot be resolved. But what happens is it drives people. The only thing that can overcome doubt that's that powerful is trying to get like perfect certainty about things. And of course, we know that we live in a world where perfect certainty doesn't really exist. Certainty is and even where people think they have certainty, I tell people it's like your brain's made out of Teflon, and the certainty just sort of slides off and slips away, essentially. So even when people think they can be certain about something, within a short time, they're now uncertain about it again, and the whole process starts over. It's like a vicious cycle, basically.
Yeah, it is a vicious cycle, and it seems like people go back to memories in the past, like maybe they have a doubt, like was I an evil person in this moment, and so they go back and they replay this event,
Mhm.
and um and that replaying of the event, would that be the compulsion, would you say?
Yeah, any attempt to relieve the anxiety caused by the OCD, which is, the uncertainty is what's causing the anxiety, basically, because it's anxiety about whether the person either harmed someone else or harm came to them in some way, or both, basically. A compulsion it can be, any of those things. It can be a mental event, that's something that person does strictly in their head, or it can be an observable physical compulsion as well. But compulsions, I like to say that compulsions are lousy solutions to the problem of having obsessions, basically, because they don't work. Basically, since perfect certainty is impossible, they're doomed to fail. They can never work. A person might get a little relief for a short term, but OCD doesn't care about that. OCD just kind of can sweep aside any certainty or reassurance or anything that the person gets. OCD is sort of immune to that, basically. So yeah, people review past events. They watch either videos of events, or they take written notes and study them over and over again, or they sit and play these things in their heads over and over. But they're as they get more frantic in their attempts, that certainly isn't an aid to memory. And now they're even more uncertain than when they first started studying these things.
What do you think, like, okay, like let's give an example that's a little extreme, like in Crime and Punishment, Fyodor Dostoevsky's character,
Mhm.
um, kind of this obsessive ruminative thing about the murder that he committed. So this is maybe a little bit different than like someone with obsessions with something that is a little bit more dubious in like moral nature, right? So
Well, yeah, it's usually situations that are sort of ambiguous where it's not really clear what happened, where the person was unsure to begin with and just started to surmise what had happened. They came up with different possibilities and probably they tendencies to latch on to the worst one basically. So yeah.
have you had patients who come to you and they believe their their intense doubt is around some moral action, and maybe like with Raskolnikov, he murdered someone, so this was an actual
Mhm.
action that probably guilt was normal. Are we?
I
Is that something that presents to you, or is it always different than that?
Well, again, that would be sort of an unambiguous situation. So, the person might ruminate on the fact that they behave badly, but they wouldn't be ruminating on whether they did it or not. No CD. It's like a perfect example is I have people who, they go driving in their car and they go over a bump in the road and they immediately say, "Oh, how do I know I didn't run somebody over? Maybe I did. It's quite possible that I did, but I didn't go back to check or anything. So now I'm a hit and run driver and I'm responsible for somebody's death." And then they may actually drive back to check and walk all around and drive by numerous times, but they don't see anything. But of course, the OCD isn't satisfied with that. The OCD will say, well, maybe they took the body away, or the person rolled under a car nearby that was parked, or all kinds of possible explanations. But they never really get to the bottom of it. They'll go home and listen to news reports. They'll do all kinds of things, and of course they won't get certainty because again, we do not live in a world of certainty. Basically, everything is pretty much. I tell everybody things are pretty much up for grabs in this world. You can't be 100% certain about most things.
Okay, I want to further get into this because the scrupulosity aspect of OCD is so interesting to me. It's like, how do you delineate like normal moral guilt that maybe they should feel guilty about versus scrupulous guilt?
Well, okay, for one thing, which is typical of most obsessions, is that no matter what the person does, no matter who they talk to, no matter what they read, no matter what advice they get, they can't resolve it. It never goes away. And also these things tend to be they tend to be worried about things that most people wouldn't even worry about, basically. They would either say, oh, it doesn't really matter, or that's ridiculous, or they'd shrug it off, or somebody would give them an explanation and they'd be happy with that and go away. But in OCD, you don't see that. Person keeps at it and at it and at it, and it can go on for years, basically. And the things that people do in response to it are generally not normal. Let's say if it's on a religious matter, what they do to deal with it is not generally proper religious observance either. It can be very extreme. It can go, it tells them that no matter what they do, they haven't done enough, or it isn't good enough, or it doesn't count, or nothing can make up for what they did. And it can be quite severe, especially with the religious ones, because many people their fears of going to hell or being permanently damned or things like that. And this is what drives these attempts to somehow resolve that and say, well, no, I'm really a good person. And there's also an additional thought that hits people with these things, which is, and it's another sort of OCD double whammy. Basically, it's like the idea that, well, if I didn't do these things, or if, why am I thinking about them? Because if I didn't do them and it was an issue, I wouldn't be thinking about it. So it becomes like sort of circular logic, essentially.
Yep. I had one patient. I'm going to change some details, of course, as I always do. But he deeply feared that he had molested a child.
Hmm.
And so he would go back to every memory of him interacting with a child, and he never, of course, molested an actual child. But he feared that he would have, or he could have, not that he would have as if he wanted to, but that he fears like, well, what if I did, but I don't remember it, right?
Yeah.
And is that something that you've seen or any?
Oh yeah, very common, very common. All these thoughts are usually preceded by the phrases "How do I know?" or "What if?" Generally that those are kind of giveaways I tell my patients. But yeah, the OCD will pick on anything like that the person thinks is immoral or bad in many cases, and they will keep going. But the problem is memory is also not that accurate. As time goes by, details get blurry, or we're not sure about whether we remember things correctly. And then the OCD steps in and says, well, you can't really remember what happened, but you did it, even though you can't be sure. You definitely did this, and you're gonna suffer for it in some way.
Going back to the scrupulosity aspect, so
Yeah.
you find that they do things that are not normally within their religious practice. Can you give some examples of like what we're talking about?
Oh yeah, people will they'll invent their own prayers, for instance. They'll make up all kinds of religious rituals. They'll constantly apologize to God, and things like this that you don't normally see in that aren't recommended as normal religious practice in whatever their religion is. I've even had people feel that they've violated codes in religions that aren't even theirs, which is how
Okay.
extreme this can become. So it's there's like no limits to what OCD can do. It's like I call it the disorder of a thousand faces, basically. But scrupulosity can be very um, excruciating. In fact, it doesn't only affect people who were normally very religious to begin with. I mean, it certainly can affect them, but it can even affect people who weren't terribly religious to begin with, and who aren't that strong in their beliefs. But it'll still tell them the same kinds of things. Yeah, you see this quite. It's a very common theme, basically. I've seen people do. I remember I had someone who stopped going to religious services because they got this thought whenever they were praying, that the thought came to, oh, how do you know you're really praying to God? Maybe you're really praying to yourself. Maybe you think you're God or you want to be God, and so they couldn't go to religious services anymore because they thought, wow, I'm going to get punished for thoughts like this. This really breaks the rules. So that's one kind of thing you see. I've had people get like morbid thoughts about God. I had a person who was constantly tortured by the thoughts that I hate God and I want God to have cancer. I mean,
Mm.
these are not kind of typical thoughts that people have, but they were just as excruciating as if it was just a normal everyday thought.
Do you find that as people like if the compulsion is to go back to the memory and sort of like rework the memory, go through the memory step by step, um, and sometimes it's almost like they want to insert or change the memory or like add to the memory or like within the fantasy they yeah, do you know what I'm talking about?
Yeah, I don't see that so much. Again, what I see more is people just trying to verify in their own mind what
Okay.
happened to get it absolutely straight, and then to try to be able to hold on to it. But they can't hold on to it. It slips away. So they never, it's like an endless task basically. It's something. It's like an itch that you can't scratch,
Yep. Okay.
basically.
So okay, like so you're getting them to sit in the doubt. What do you tell them to get them to just sit in the doubt?
Well, we do. First of all, I think before you begin any therapy, you really need to do a good round of like psychoeducation, basically. So what I first try to do is really teach people what the nature of OCD is, what they can expect from it, what it requires to get better, and why we have to do the things that we do. Because I don't believe in asking people to do things if they don't understand why they have to do them. Because I want them to be partners in their own treatment, basically. I'm kind of that way myself. If you ask me to do something, I'll say, well, why do I have to do that, or what's the importance of it?
Okay.
So
So
that's the
so
first step.
so can we play this out? So I'm coming in and I'm the patient. So just take me through what you would normally say.
Oh gosh, that would take a whole session in
Would
and
it?
of itself.
Okay.
Well, one thing I do give patients, it's a document I put together years ago. I made it for my new patients. It was called How to Succeed in Your 25 Tips on How to Succeed in Your Behavioral Therapy, and it became kind of popular actually. I didn't realize it at first, but the OCD Foundation actually has it on their website now, and a lot of therapists have told me they give this to their new patients also because it spells out all the basic principles and ideas so that I want everybody to start with the same body of knowledge, basically, so that they're informed consumers. So I explained to them, sort of in a nutshell, that OCD is very paradoxical, that all the things that they thought were going to help them in the past, like compulsions, only made them worse, and that all the things that they thought were going to make them worse, like facing the thoughts and the situation, will actually make them better. And I explained to them that the only way to overcome a fear is to face it. You can't run away from or escape fear because it's an internal experience. You can't run away from what's inside your own mind, basically. So we don't try to do that. And I say we can't control thoughts either. So you can't push a thought out of your head, or sometimes I tell them, I say we can't turn off the faucet, basically. So since we can't control thoughts in that way, what we can do, we can control our response to the thoughts, because I tell them that you may not control what pops into your mind, but you can control how you react to it and what you do about it. That, I said, is totally under your control. OCD can't make you do compulsions, although people think that at first. I say, no, you came up with the compulsion as a way of managing the doubt and the anxiety, and then you practiced it hundreds and maybe thousands of times to the point where it became so automatic that it feels like OCD is making you do it, but it's not. I say anything you've learned something, and anything that you've learned that way can be unlearned. It's not hardwired into your brain, so you can unlearn it through practice, basically. And this is how I view it, basically. So I tell them the goal, since we can't escape or avoid, the goal is, and I love this word in regard to its coexistence. I say you have to learn to coexist with the thoughts, to be able to say, okay, I can have that thought, but I don't have to do anything about it. It's not important to me. I don't have to act on it in any way. Ultimately, I mean, that's the ultimate goal. That's not the early or intermediate goals, but that's what we're going for, basically, is to be able to live with those thoughts. And we're trying to, overall, we're trying to build tolerance. We're trying to increase the person's capacity to experience these things without, again, having to do compulsions. And one other thing I like to tell them, I say the anxiety is not the problem. The compulsions are the problem. The compulsions are what are going to tie your life up in knots, basically. The anxiety, if you stop doing compulsions, that means you're staying with the anxiety, and ultimately you're going to get over the anxiety. But if you think the anxiety is the problem, you're just going to do more compulsions. So I think the I try to make it very clear why we do what we do, and how it's supposed to work. And I tell them it's a work in progress. It's a gradual process. Nobody, builds up their tolerance immediately. It's like any training program. If you wanted to learn how to play a sport or play a musical instrument or anything like that, you would have to practice regularly and intensively, and then you would become good at whatever it was. And that, I like the old saying, habit is overcome by habit. So we
Hmm.
develop new habits to displace the old ones, and the less they practice the old habits, the weaker they get, and the stronger the new ones become, and it becomes easier to resist and react appropriately to these things. So that
Okay.
in a nutshell is what I tell them.
Okay. So what if the compulsion becomes repeating the things that you've talked about, um, as a way of dealing with it? So it's like you need to sit with the doubt. So repeating, you need to sit with the doubt becomes the compulsion.
Well, interestingly enough, I give people homework to
Yeah.
do every week
Okay.
on their own therapy homework, but every homework assignment, the first three items on their list never changes. It remains the same throughout therapy and even after therapy. And the three items are: number one is we say try to agree with all obsessions, let them be there, uh, don't and agree with them. In other words, stay with the thought, let it be there, say it's true. Okay. The second point we tell them is, uh, let's see if I can. We say, do not study or analyze the thoughts. Only agree. Don't try to figure out what they mean or where they came from or anything else about them. Just say they're true, and leave it at that. Okay. And the third point we say is stay away from um, all reassurance, basically. To not seek reassurance from other people or from yourself or in any other way. So again, they're staying with the anxiety. And I tell them, I say, treat all these situations where you get thoughts or your anxiety comes up, treat them as opportunities to practice. Don't say to yourself, oh, why did that have to happen to me? But say, okay, this is giving me a chance to work on this now, and I'll get better if I face it the way I'm supposed to, essentially. Now, we do give other homework in addition to that, but I call those three our permanent assignments,
Okay.
Based.
Okay. So then what if the person, like, it becomes a compulsion to go back to your handout and read it over and over again?
Well, then we tell them to, obviously to stop doing that and to instead tell themselves that they don't really understand the information and it won't be able to help them and they're never going to get better because they're untreatable. And
What?
and but that works.
Okay.
People report they feel when they start agreeing with the things they think they're going to get worse. But many people report to me and say, no, I felt sort of like a sense of relief, like I could let
Okay.
go. I
Okay.
didn't have to do anything.
So that's good. So I have had patients with OCD who say, I feel like I'm going to get worse. And that's like an obsession of theirs, right? That they're
Mhm.
like not
Yeah.
getting better, that they're going to get worse. So you would have them agree with that. I am going to get worse.
Yes, absolutely. OCD, it's interesting. I believe it's the only disorder that really attacks its own treatment. That it tells people you don't know how to do the treatment, you can't get better, nothing can help you, you probably don't have OCD, and so on. All these things to get a person discouraged almost and to want to give up because it tries to make them feel hopeless in a way. Again, it's just part of not everybody's, but many people's OCD. And in my 25 tips, I actually warn people to expect that that may happen to them.
Okay. So like let's say they have some moral, scrupulous thought, like I'm a pervert,
Right.
or something like that. And then so this example, this guy who goes back to his past, which it becomes like a thought over and over, right? Do you so does number one try to agree with all obsessions?
Yeah,
Do you tell
we
them
work
to
up
agree
to
with that?
these things basically. We
Like,
start kind of gradually and build up, keep raising the bar.
so what would be
Starting
a what would be gradual for that? Because that seems
well,
like,
we approach the idea that yeah, there are people who molest children. They're really nasty individuals. They should be separated from society and locked up and everything. And then the next thing we go is there are many people among us that we don't even know they're like this, but they are. And then we move on to say maybe I'm like that, and from there we say, yeah, I very well could be like that, and then I'm probably like that, and even move up to yeah, I'm definitely like that, and I definitely did these things, and all the rest that goes along with it, basically. So it's a gradual escalation of what we do. Obviously, if we hit the person with the worst stuff immediately, we're going to scare them away from therapy. And a lot of beginner therapists, unfortunately, take people too far at the beginning because they're so zealous about getting people recovered that they push people over the edge. So then they lose their patience.
okay, so let's say they believe that they did this horrible thing in the past, right? And so now they're saying to themselves, I know I am this type of person, right?
Hmm.
That would harm, let's say, harm women. Like I am a person that would
Right.
specifically do this malevolence towards women. Okay. Um, so now they're saying that that's true. What if they have like a self concept now that's like kind of, it's hard for them to hold that. Like it's like their idea of themselves doesn't have
Well,
the
see,
it's
one of the hallmarks of OCD again is that these thoughts are what the person recognizes that this is not them deep down. In other words, one of the term that they usually use, a technical term, is that the thoughts are ego alien rather than ego syntonic, meaning that the person says this is not who I am, which is why it's even more disturbing because it makes the person even more puzzled as to why they're getting the thought to begin with, which is what's even scarier, basically. So I've in all the years I've been doing this, and I've been doing this for a long time now, I have not seen that happen with people, but I have seen people lose their fears as a result of staying with it. There's a Zen saying I always like, which says that facing what you fear is a way of getting closer to the truth. Problem is, people never stay with these things long enough to observe what really happens. They're too busy escaping. So what happens
okay.
ultimately, if they stay with it, the thought, you know, it persists, but then after a while, it kind of peaks off and then tends to subside. And then the person says, wow, if I just stay with this, it's going to get better. If I take the initial discomfort, there'll be less discomfort for me down the road, but I have to, wait patiently for that to happen.
Oh, well, okay. So it's like you haven't really seen people. Um, I think you both say if you bring it on too quickly, the person will leave treatment, but also there's a progression in sort of like um, progressing towards like this idea of like, you know, try to agree with all obsessions. So
Hmm.
like, let's say the obsession is like, I think I may have murdered someone. Um, like, and that. So would the what would be the progression to agree with that?
Again, that there are murderers among us, and anybody under the right circumstances could commit murder, and maybe I actually am capable of that, and maybe I did do it, and then we move to I did do it, or at first I'm capable of it, and then yeah, I probably did do it, and then yeah, I really did do it, basically. And the interesting thing is, as I say, the further on we go, it becomes harder and harder to evoke anxiety in people. It takes more and more, and by the time we get to the end of the process, if people say, "How do you know when you're recovered?" And I say, "Well, when we can't come up with any homework assignments to get your anxiety going anymore, when we can't bring on the anxiety, no matter what we do, then we say you're recovered because the thoughts no longer have any impact on you, and you can let the thoughts be there and coexist with them without having to tie your life up trying to deal with them."
Okay, so let's say they're spending 6 to 8 hours obsessing per day. Um, do you add homework on top of that 6 to 8 hours?
Well, first of all, the homework is going to give them something to do instead of just sitting there and obsessing. It's going to give them some. We're trying to give people tools, basically, as things that they can actually use to help themselves, and we try to treat it very comprehensively. We try to hit the OCD from many different directions. There are writing assignments, there are recordings they make and listen to. We watch videos online. We read articles. We go places that might evoke the thought, and take part in activities that may bring on the thought. So we try to, I tell people we're trying to surround it and hit it from all sides so that you're confronting this thing, and you learn again that the answer is to face your fear, and that you can't escape and avoid it, that that's impossible, that you're trying to do something that you'll never succeed at. So we're going to do something we can succeed at, basically. So that's essentially what we're trying to do. But we want to really, I tell people the goal is zero compulsions, no compulsions, which is attainable. It really is. We can't. I don't promise zero obsessions. I say no. You're probably going to get thoughts. It's a chronic disorder, and we can't just medication may lower the level of thoughts somewhat, but even that's not a cure. It can't stop the thoughts entirely as a rule. So in fact, I tell people the purpose of medication, and they usually ask me about it, is to help you to do the therapy, because it gives you an assist in the therapy, and the therapy is ultimately what really changes you and
Yeah,
all. So.
I talk to people about that as well. I think it's the same with like, yeah, social anxiety. It's like maybe a little medication allows you to socialize, but then after socializing for a number of years, now you may not need this medication,
Mhm.
right? Um, okay, so break this down specifically with the doubt. Like what and with the scrupulosity writing assignment, like give me an example of like what that would be.
Well, first thing I do is I have people write, especially for directed sentences, 25 times a day. Like, I could murder somebody, for instance, write that 25 times per day. And it sounds kind of simple-minded, but a lot of my patients tell me that's one of the most effective assignments, interestingly enough. Then we ultimately move on later in the therapy to having the person themselves write their own worst thought of the day 25 times. I let them decide what the worst thought is. And in addition, I give them directed topics to write two-page compositions on and then record them into their phone and listen to them 6 times per day as a rule.
Okay, and the compositions are like what? Well, give me an example.
How
2 minutes.
like one kind of composition might be uh, how I can't be sure that I didn't murder somebody, or what it was, why I really like killing people, or how I plan to commit my next murder, or things like that,
What if the
basically.
FBI gets a hold of that plan to murder?
Well, so far that's never happened. So
Okay.
I feel the odds of that are rather small.
I'm see my doubt's kicking in. I'm like,
If a patient asks me that, I say, I don't know, maybe they will. I
yeah,
don't
right.
reassure. I tell them don't come to me for reassurance because I'm not going to do that either. I'm not going to participate in compulsions with you.
Okay, so give me an example of like how they want you to reassure and
Oh
how
well,
therapists often reassure.
well, for one thing, that they'll sometimes they'll just ask about the treatment. Say, oh, am I really going to get better? Can I recover? Is there any hope for me? Things like that, or is the therapy really working? Stuff like that is one kind of reassurance. Another one is they may ask me directly about the topics. They say, well, you've heard everything I have to say. Do you think I did that thing? Whatever it was, and I'll say, I don't know, maybe you did.
Okay.
In fact, they'll even say, yeah, you probably did do that. And but the funny thing is, instead of like freaking out, the person will just sort of look at me and smile because
Ah,
they know exactly what they're doing and they
yeah.
know the answer they're going to get. So,
Now, before you say that, do you preemptively warn them like, hey, I'm not going to reassure you because that's part
oh,
of
at
your
the beginning of
compulsion?
therapy, yeah, that's part of our introduction. Basically, is that I don't do compulsions with people, and that includes reassurance. And in fact, I'll instruct family members to not reassure them either if like they're not supposed to ask for reassurance, but if they slip, the family member is supposed to say, "Sorry, I'm not allowed to discuss that with you."
Okay, so the so if this person has family, like what how do you engage the family to not reassure?
Pretty much the same way I instruct the patients to not ask for reassurance. I explain, how harmful this is and what enabling is, and if they really want their loved one to get better, they're not going to participate. I say, if your loved one was an alcoholic, you wouldn't go out and buy a bottle of vodka for them. I said, so this is really kind of the equivalent of that. So we're not, you either, like they say, either you're part of the solution or you're part of the problem.
Okay. Do you meet with families? Like, will you meet
If
with
the
the
patient agrees,
yeah.
yes. In fact, a lot of them want me to because the families often don't understand what's happening and they want me
Mm,
to explain. And that's usually a great relief to family members because, I not only explain the nature of the disorder and why they're seeing what they're seeing, but also why the person has to do the therapy because, most people aren't that acquainted with behavior therapy and, they see the person doing these homework assignments may look pretty weird to them if they're not familiar with it. So I explain what they're going to see and what that's going to be like and how they can help and also how they can hinder.
hmm. Okay,
So, so
what are
yeah.
your go-to articles you have them read? Like what is that about?
Well, on my website, I have several dozen articles about all different types of OCD. I started out many years ago writing like a series of articles on the nature and the treatment of different types of OCD, basically different topics you're likely to see. So by now I've got quite a few. In fact, I just wrote one on it's not on my website yet, but it's in the OC Foundation newsletter about obsessions about suicide and all, which nobody ever writes about and which really throws a lot of therapists off track,
Okay, so
basically.
so what is the obsession? What are they saying to you?
Oh, the thought is, oh, I'm going to kill myself, or maybe I really want to kill myself, or they'll get like almost like an urge, like saying, yeah, I've got to go kill myself right now. Or if they're cutting something with a knife, they say, how do I know I couldn't take this knife and cut my wrists? Or all kinds of things. And then again, as with other obsessions, the person says, well, if I didn't want to commit suicide, why am I thinking this? But they have no history of suicide and they're horrified at the idea of it and would never want to commit suicide. But it's the idea that they can't stop thinking about it that really sends them basically. So again, we have to teach them that yeah, you're going to get thoughts about killing yourself, and you're going to have to learn to coexist with those thoughts because we can't just simply shut them off.
Yep.
So that's what we do.
So let's say you have like a medical student who's having these obsessions um during a rotation and they're just like, I cannot focus. I cannot focus. Dr. Peter, help me. Help me figure out how to like how like what do you have them sit with the doubt and sit with the uncertainty and not do the compulsion while they're on a rotation on
Well,
life, you
sure,
know?
because what can they do? People have jobs, they have things they have
Yeah.
to do. They can't just stop in the middle and do therapy. So, yeah, I mean, they can still in their head agree with things even if they're in the middle of something else. And also I tell them, I say, look, we're not going to get this under control overnight. This is a process. It's a retraining basically, and it takes time to retrain yourself because you trained yourself to do compulsions. Now we've got to train you to do the opposite, basically. So I tell them don't expect overnight improvement. I said, but if you take care of your daily goals with your homework, eventually it will add up to something, and the larger goals will be taken care of if you take care of the daily goals.
What if there's certain you talked about going places that might evoke the thought?
Yeah.
What kind of places are we talking about?
Well, for instance, I have a patient who can't walk across bridges or walkways because they get the thought that they might want to jump off, basically, and kill themselves. So we have them do just that. We have them walk across these things. Sometimes they can't do it all at once. Sometimes I'll have them just walk out a little way on the bridge or the walkway and then come back. But then each week we try to go further and further, and ultimately they can, go all the way across and back. And then they learn, okay, I can think this thought, but I'm not necessarily going to do anything about it. But you can't just tell them that. They have to see it with their own eyes. Basically, they have to learn through experience. And this is how you overcome any fear. Like we said, you have to face it. If you look at anyone that ever overcame a fear of anything, okay, you'll see that they did it through facing that fear one way or another, but they couldn't run away from it.
What if you had a patient, like say they had OCD at baseline, so they've had like hand washed in the past, and then something traumatic happens, right? And then the obsessions get centered around the trauma in like a new way. Like for example, let's say uh, they were sexually assaulted, and so now anything around sexual assault, anything in the news on sexual assault, any people, any of that brings up this kind of like idea in their mind that like, oh, I may be sexually assaulted in the future, right? It seems like a trauma, but it has like a very obsessional component with their compulsions. Now they have new compulsions of going back to memories where they maybe were walking in places, trying to
Sure.
remember like were they sexually assaulted during that time, and so forth. Like how would you approach that because you have both
Well, you know,
OCD and the trauma, right, mixed in.
yeah, yeah. Well, sometimes you have to make a judgment call as to, what you want to work on first. You can't do everything at once. Clearly, I mean, that would be, there's not enough hours in the day or enough homework you can give someone to do it all at the same time. If the PTSD was bad enough, you'd go for that first, basically, so that the person could then settle down and do the behavior therapy. But interestingly enough, exposure therapy is also an approach to treating PTSD, and I have used it on quite a number of occasions. And in there, we actually have people make recordings of the event and listen to them and listen to them daily. And then each week we revise them in terms of as they're listening to these during the week, they usually remember more memories and more sense experiences and things like that. And then we keep building that into the next recording. And we keep going and we keep going. And people start out, being upset at first when they listen to these things, but it's very interesting because as the weeks progress, you watch them actually responding with less and less upset as they listen to the recordings, and finally, it seems to aid into putting these experiences back into like long-term memory storage, you might say, instead of being at the front of their thought process. And when that's more under control, then I would say you'd have a very good chance of then working on the OCD. But and with along with parts of PTSD, sometimes we also, again, as in OCD, we have people go places and do things that evoke, later on in the therapy. We don't do that right at the beginning, but that evoke, again, thoughts of whatever the incident was, and to confront it in some way, and that actually helps.
Okay. So I hear you kind of you're doing this recording composition things. Are you doing that with them? Are you recording it in
Yeah,
session?
I give them a topic, and then they write it's 2 pages usually because that works out to a 2-minute recording, which is what I've learned seems to be pretty effective. So we have them write it themselves. I mean, I'll have them bring it in and play it for me. And listen, if I think it's good, I'll tell them. If I think it needs amending or it needs additions or things like that, I'll tell them that also. But I tell them, I say, this is part of learning to be your own therapist, basically, because ultimately, you're not going to be in therapy forever, and eventually you're going to be out there on your own, and you have to be able to handle these things yourself and use the tools that you learned in therapy. You have to, like I said, you have to be your own therapist because I like to say that getting well is 50% of the job and staying well is the other 50%. So you better have those tools and use those tools on an ongoing basis since we don't know how to cure OCD at this point in time. It's chronic.
So, okay, so do you find that people with OCD they have to continually kind of um, change the way that they what they're recording based on like new levels of obsessions and compulsions that pops up throughout their life?
Oh, absolutely. In other words, if a recording, I tell them to listen to recording until over the course of several days, it's really boring, basically, because I say you can't be bored and scared at the same time, essentially. So then we have them upgrade the recording to a new level, and we keep doing it. Eventually, we may reach a level where the person says, you know what, I can't, there's nothing I can make up as a recording that's worse than what I've already done. And we know that we've pretty much exhausted the topic. And usually at that point, it really doesn't bother them very much at all. So that's what we're aiming for here. We're trying to, I say we're trying to make you obsession proof,
Okay.
basically.
So they're so the okay with the moral scrupulosity, for example. So what you're saying is that they'll have new kind of obsessions that are even worse,
Hmm.
and you have them kind of integrate that into new recordings.
Sure, you can't ignore them. So yeah, you have to work on whatever comes along. In fact, when it comes to obsessions, I tell them to always expect the unexpected because you never know what new obsession might be around the corner. So since you can't prepare for every obsession, you have to prepare your tools basically. And all OCD is basically treated the same way. So we don't, you know, different themes are not generally treated with different therapies. The same principles apply to all OCD. So that's what I teach them. And I say if you understand the principles and you know how to use the tools that are in line with those principles, you're going to do very well. You're going to, like I said, you're going to be your own therapist.
Okay, like let's say you had a patient who had this obsession that something bad was going to happen to their son. Okay, and maybe their son had
Uh-huh.
some illness, but he imagined it would get worse and worse and worse, and
Right.
the son would end up dead. So walk me through what that would look like with this kind of like agreeing with the obsession.
Well,
Um,
we talk about, people, how some people have particularly serious illnesses, and then some people, that can really damage them. And then if we move on to some people have fatal illnesses, and then we say maybe your son has a serious illness, and maybe your son has a fatal illness, and he definitely has a fatal illness. Your son's going to die. There's nothing you can do to save him. Blah blah blah. We go the distance. We try to come up with the ultimate confrontation here, basically. And when a person can tolerate that, what else can OCD do to them, basically? When the person can face the worst of the worst without getting anxious and being able to say, okay, I can be with that thought, but I don't have to do anything, then they're good, basically. Now they're managing it. It's not managing them.
okay, and so when you talk about the progression, like how long do you start with this idea of some people have a particular
You
illness
know,
that
it,
might
it
damage
varies
them?
with the patient basically and their reaction to it. If at the like I'll have them listen to something say for a week and they come in and I'll say, well, when you listen to this, does it still bring up any anxiety? And they'll say, no, I'm pretty bored with it. I don't care. I'm ready for a new. They'll even tell me they say I'm ready for a new recording. They do. Because they want to
Okay.
get better.
Yeah.
But otherwise, or they'll say, no, I think I want to stick with this one for a while because I think there's still something in it, and
Hmm.
I feel like I need to work with this some more before I move to the next one.
What is the 2 minute write up in this scenario? What would they be writing up? Like what would they be
It
telling a
depends.
story
It
of?
depends on the thought, basically. I let them determine it because they're more familiar with what's going on in their head than I am.
So
Basically, they know what I say. The OCD gives you all the material you need to make this recording. Just use what it's telling you.
do you think this would work in someone who doesn't have OCD, who just has maybe anxiety?
Possibly, possibly. It depends. Whether they're just a generally anxious person or they're anxious about something specific.
Well, let's say it was specific. Let's say this person with their kid, maybe they're not OCD, but they have this deep fear that
Yeah, I think it would work. I believe it would work. in fact, I sometimes use this with people with other type, like even in like I've done it with people with fears of public speaking or social anxiety or even with phobias and things like that. So yeah, yeah, I think it would work because again, like we said, facing what you fear is a way of getting closer to the truth. You can, again, you wear these things out. The person just gets tired of hearing it. It's like they say, oh, enough already. I've heard it. What a psychologist friend of mine put it very well. He said the treatment. He says it's like watching a horror movie 1,000 times,
Hmm.
which I think is it's kind of a good image for that, basically.
Okay, so you have them like say that the obsession is true, that this will definitely happen,
Yeah,
and then you have them um, record a 2 minute
yeah,
sort of like story of that happening,
yes.
and then maybe over time that story changes, and you have them re-listen to it until they're like, I'm listening to this thing and I'm really bored, and I
Hmm.
I just don't want to do it anymore. It's just really boring. Is that the
Yeah.
goal?
Or if there's still parts of it left, we'll make another recording.
Yeah.
An even worse one if we can. If we can't, that also tells us something. That's kind of diagnostic in a way because now we know we've gone the distance with that particular thought.
And I guess I'm like still confused, like if the person is confused on if it is true or not. And it really does change their perception of themselves, right? Like if they did hurt someone, maybe they did hurt someone a little bit, or maybe they could have hurt someone, but they didn't hurt them. Or like, but they're
Uh,
if they assume that they hurt the person, like that makes them out to be a bad person. So and that labeling of themselves as like a bad person, like is that something that they're labeling?
um, well, they would only assume that that's so if they could verify that what happened really happened. But it's always a matter of doubt. Remember, we're talking about the doubting disease. I mean, if a person has like all kinds of outlandish thoughts that they 100% believe, now we're talking about a delusion. We're not talking about an obsession anymore. An obsession is a doubtful, repetitive, negative, intrusive thought, basically. So if it meets those criteria, then as I say, I've been doing this for you know more than 4 decades now, and I've never seen it change anybody's perception of themselves. In fact, if they really believed they were bad, they probably wouldn't be struggling against the thought. They just say, okay, well, I'm bad. That's me. That's I accept it. That's who I am. But it's not there. That's why they're going to these lengths to prove that it didn't happen because they don't think that that's them. It's as we said, it's like ego alien if you want to use that term, basically that old psychoanalytic term. That it's not native to them. It's not who they are. It's like, in fact, a lot of people say, it just came to my head one day. I don't know where it came from. It just started, or sometimes it's not even the result of something that happened. So no, I've never. Again, I've heard people bring this possibility up before, but people. In fact, when people first start therapy, they'll say, "Well, isn't this going to convince me that I'm that person, or that I'm a really bad person?" And I say, and I tell them, I say to me, I said, yeah, I'll reassure you about this. I won't reassure you again because I'm not in the reassurance business. But no, it's gonna have the opposite effect, and you're eventually going to get tired of hearing it. So it doesn't seem to work that way. I mean, I've never believe me. If I saw that happen, I would have abandoned the approach years ago. But people get better. They don't get worse. And
Mm-hmm.
and eventually people will say, in fact, I'll give you a good example. I had a guy who had thoughts about murdering his girlfriend, and we did everything to confront the idea that, yeah, you're going to kill her. We actually had she was in on it too. She knew what his thoughts were because he had told her, and she was very understanding. So we actually have her take part in homework. He would sit next to her while they were watching TV, holding a big knife in his hand, and she had homework to say to him, "Please don't kill me," several
Oh,
times a day,
and
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 all.
what and what would he say? Would he say to her, "I'm going to kill you"?
Not so much. Well, I didn't really do that so much, but I had him, holding and using implements that he could have used to kill her around her and in situations. But the interesting point of all this is that when we got to the end of the therapy, he said, he said, you have given me every opportunity to kill my girlfriend, that if I was really going to do it, I would have done it. He said, but I've approached this every possible way. He said, and he said, I see now that, it was just an obsessive thought, and I'm not going to do it. So he was able to pretty much live with the thought. Even if he still had the thought, he could say, well, I tested this out fully, and I'm just not going to do it. So that was the convincer for him.
Like, what if this was like a very passive guy who has kind of like a difficulty in being in touch with his anger, and he had kind of disavowed his anger towards his girlfriend, that he had, and it was coming out with these kind of extreme thoughts. This is obviously a different problem than what we're talking about, but I could see
Yeah.
you kind of see more of
Um,
the OCD. I may see more people who have like a hard time being in touch with their anger at times too.
well, for the purposes of OCD treatment, I would say, yeah, you are angry and you are containing this anger, and eventually you're going to let it out, and eventually you're going to kill this person and do all kinds of other awful things. I've had people who even had worse thoughts where they thought they were potential mass murderers and all, and we
Yep.
we work on that. I have them, read biographies of mass murderers and watch
Mm,
videos about them and read stories and
okay.
tell them how they're going to be. I have them do compositions and recordings on how they plan to become mass murderers and how they're going to carry out their killings and all. I mean, we hit every aspect of this, and by the time we get to the end of it, the person's just like, okay, I've had enough with mass murderers already. I'm tired of hearing this.
so so by the end of it, they're not the Columbine kids that you were treating before. It's like,
Yeah,
oh,
yeah, no, you really see like a transformation in these folks. I mean, and I'll tell you another thing, which is that I don't just it's not as simplistic as just trying to change people's behavior. I tell people, I say, along with changing your behavior, you have to change your beliefs. You have to change I call it your philosophy of things, the view that you take of things. And I say it's your beliefs about uncertainty, your beliefs about risk in life, your beliefs about anxiety and internal experiences like that. And we work on changing that along the way too. We don't just it's not just as simple as behavior change, because if you change your behavior but you're still thinking the same ways, you could easily slip back into symptoms again. So I say if you really want to stay well, you have to regard these topics in a whole different way than you have before. And so we work on that as well. So I don't want to make it sound like it's all behavioral. There's cognitive aspects to it also, where we challenge the person's beliefs about discomfort and about anxiety and about uncertainty in life, and get them, again, it's like the 12-step thing where you change what you can change and you accept what you can't change, basically. And that's what we try to work toward.
okay. So yeah, break that down a little bit more. Like like let's say someone says, well, but in most areas of life, I am very certain.
Hmm.
And so why can't I be certain about this as well?
Well, I explained to them, number one, nobody can predict the future, no matter how certain they think they are. And number two, I say we can't even predict what's going to happen 5 minutes from now in life. So how can you, this kind of statement is illogical, basically. You may think that everything's certain, but things can happen in a blink of an eye that change everything. You could be sitting at a stoplight in your car and somebody rams into you with their car, and now you're physically disabled and damaged person. I mean, how could you have foreseen that, for instance, or becoming ill with some kind of physical illness that you couldn't foresee? And also, I say there's no certainty. In fact, my favorite Zen author, she says, if you're looking for certainty, you're on the wrong planet.
Hmm.
And I agree with that. I don't think there is very much certainty. We can make kind of rough predictions or educated guesses, but we can't be absolutely certain about anything. Life, I've been around a while now. Life has taught me that you just can't anticipate everything that could possibly happen in life, good or bad, basically.
Have you seen uncertainty as well in like domains of like relationships? Like I'm uncertain that my boyfriend loves me type of thing. And
Oh,
this
oh
is
yeah, that can be a big one in OCD too. And again, what I explain to people is again, it's on a philosophical level, is that you life does the universe is not set up to give us everything we want, and you can't. There are no written guarantees in life. No matter what you do or no matter what you undertake, there's no certainty that it's going to work out or that you're going to get what you want. We go out there, we we try our best. We're all imperfect human beings. We do the best we can, and then whatever happens, happens. More than that, you can't really ask for. But I tell people, if you want a written guarantee, forget it. Life's not going to give you that. There's no such thing.
And then what about the this kind of idea of expecting discomfort? What if how could you challenge their idea that they should be comfortable or they should not have any anxiety or
Well, I try to point out that there's this basic flaw in their beliefs, basically, that they have this, I like Zen a lot because it teaches good things, but one thing that it teaches is not to make demands, basically. And what these people, one of the things they're demanding, they're saying is that things that I don't like in life shouldn't exist, or things that I find disagreeable shouldn't happen to me. And I say that's an illogical statement because you can't control those things and you can't guarantee them. Whatever happens, happens. And like it or not, your goal is to be flexible enough and adaptable enough to be able to deal with whatever comes your way in life, because life is like that. The financier Malcolm Forbes, I always like something he said. He said that just getting out, and he was a big risk taker as an investor, but he had this saying. He said, just getting out of bed in the morning is taking a risk. I think people just have to accept that everything is risky. If you start a relationship, you're risking that it may not work. Or if you take a new job, you're taking the risk that maybe you won't like it or it won't suit you, or anything like that, basically. It's just the nature of life.
have you seen people come in and have the fear of being sued? Is that like in a new job or something or
Um,
a new situation? Is that ever
not
part
a,
of the obsession?
not so much a big one, really. I haven't encountered. I got to be honest, I haven't encountered that one that much. Usually, it's things that are much worse, like going to jail or going to hell or being murdered, or all kinds of things like that, like really severe things. Not, in fact, even my attorney patients don't seem to worry about that.
I have one attorney patient and he has a frequent fear of, you know, being taken to court or his board license being removed.
Yeah, we say, well,
Um,
yeah, you know what? Sometimes that happens to people, and like we said, expect the unexpected. I mean, life, that is the nature of life. And in fact, I mean, it is unpredictable. So we just go from day to day, moment to moment, and hope for the best, do the best we can, do our due diligence, and we hope things work out. If they don't, then okay, we try to, like I said, adapt and deal with it as best we can. But that's all we as human beings can do. There are limits.
okay, so like let's talk a little bit about sitting in the doubt. Like what do you when they're sitting in the doubt, one thing that I've done to try to get them away from obsessing about the thoughts of how to sit in the doubt is just sit in the bodily sensations of the doubt. And I'm
Mhm.
wondering if this has been helpful for you as well.
Well, people do get a lot of physical sensations that are often accompaniments to anxiety, and we have them learn to tolerate those too. In fact, I have a patient who gets like these dissociative episodes, and part of her treatment is to just like we do in panic disorder. Basically, we get the person to stay with the physical sensations and learn that. I tell the person, to say you're confusing, um, you're confusing discomfort with danger, basically. Like anxiety is uncomfortable, but it's not dangerous. It's adrenaline in your bloodstream, basically. And I try to explain the physiology of it to them and explain, that's what's actually happening, and that it's a normal hardwired experience that evolution has equipped us with. They said, you want to be able to get anxious about some things because that evolution has equipped us with that to help keep us alive, to run away from danger or to fight if need be, and all the fight or flight response. So we come equipped like that. And there's no way we can't shut that down, basically. But if you start getting anxious about being anxious, you're only going to make yourself more anxious. You're not going to get less anxious. So it's learning to accept anxiety along with other things that happen in your life, things that you can't eradicate, that you're going to feel anxiety, so you have to learn to tolerate it. I mean, what choice do you have?
So let's say they start like obsessing about how their anxiety is going to eventually lead to them,
Oh, so we
dying.
agree with that. We say, yeah, that's what's going to happen. It's true.
But then they said, but you just told me that it didn't it won't
Right, now I
happen.
say, well, now you're looking for reassurance, so don't do that. Just agree with the thought.
That's good. You're like,
Like,
it's
this is not a democracy. You have to do what I say, and if I say you have to do that, that's what you have to do because that's what's going to get you better.
Okay. And they say, well, I doubt that you have the knowledge to get me better at this point.
Right. And I say, well, I say, who? Sometimes I will try to give them a little objectivity and say, well, who do you think's telling you that? And then often they'll say, yeah, it's my OCD. I mean, because as I say, I explained at the beginning of treatment that it's going to give them doubts about the therapy, about me, about their ability to get well. So it's going to fight its own treatment. And in fact, for some people, that's the main part of their OCD.
So the one thing you don't have them say and assume that it's true is that you're incompetent. You don't allow them that
Oh no,
obsession.
if they're obsessing about that, no, I'll say, yeah, right. Dr. Penzel doesn't know what he's talking about. I'll have them do recordings about that. He's informed. He doesn't. He's misdiagnosed me. I don't really have OCD. I'm getting the wrong treatment, etc.
Okay. That's
So
good. I
again,
like that.
the trick is you go toward the anxiety, never away from it. I always tell them what we're trying to achieve here is the opposite of avoidance.
So when a patient under those circumstances writes down 25 times a day, Dr. Fred Penzel is an incompetent therapist, and
Right.
they bring you those sheets of hundreds of writings, you don't get offended.
Not at all. Number one, I know why I'm doing what I'm doing, so it's not like a personal thing. But secondly, actually, I don't make them bring this stuff in. If they tell me they've done it, I trust them because I say if you don't do the homework, then the only one that's going to have a negative effect on is you, not me. So you're not going to get well. So no, I trust everybody.
Let's talk about like comorbid issues and how that complicates it. Like, let's say they have like
Yeah,
bipolar and OCD. I think there's a genetic link there. Have you seen a lot of patients with the combination of those things?
I've seen some.
Okay.
Yeah, usually I'll refer if they're not under treatment for that, I'll refer them to a good psychiatrist to get the bipolar under control first, because if that's not under good control, that could really interfere with the therapy in a major way. And most people who have bipolar who come to me have already been treated for it, and that part's doing okay, but it's the OCD that's really causing them problems.
Um, how about like personality disorders and OCD? Do you is that something you're seeing often, or is that something that
Well,
you found?
it's a really interesting topic, I have my own views on that, which
I
some
want to
people
hear
might
your
not
views. You can have different
agree.
views. It's fine.
Yeah, my view is that I believe, well, first of all, nobody can really truly define what a personality is. One of my old professors used to say that personality is what personality tests measure. So, so,
Yeah, that's
but
right.
basically, um, again, I don't treat personality disorders, quote unquote. I have questions about some of them. For instance, uh, obsessive or you know
Obsessive compulsive personality disorder.
obsessive compulsive personality disorder, I do not believe is a real entity. I believe that it's something that they took people who were just kind of perfectionistic and pathologized them. Basically, they turned it into a disorder. And I think no, there are some people who are very perfectionistic and very definite about the way they want things, and they're not unhappy being the way they are, and they get satisfaction from being it. So for us to, homosexuality used to be classified as a disorder, and now not so. But I think that these people also have been tagged unfairly with a label that is really unjustified. And I think that yeah, there are perfectionistic people in this world. There's like a whole spectrum of people from people who are completely lackadaisical, who are over perfectionistic, but I don't think it's a pathology. I don't think it's a disorder, and that we should be trying to cure them.
Right. How about like borderline personality disorder and OCD? Is that because
Borderline, again, I think there's something there. If it, I generally speaking, if I have someone who's having trouble regulating their emotions, and I don't know if that by itself would constitute borderline personality disorder, but I will send them for DBT
Mhm.
treatment because I don't, again, I don't specialize that. I know my limitations, and I treat what I treat. But I know people who are more expert in that, and I would refer these people for DBT treatment.
What about like schizophrenia and OCD?
I've treated people with schizophrenia and OCD, but as I say, like the bipolar people, generally their schizophrenia has to be under good control before I can really treat them. I mean, if somebody's sitting in my office actively hallucinating, we're not going to get very far in treatment. And I really feel for these people because they really suffer. But I would again make sure that schizophrenia was being properly medicated, and that the thoughts were under good control, and then we could certainly work on the OCD, and we do, and I've had success with these folks.
Oh, what about like eating disorders and OCD? Is there any
Uh,
time where it's more OCD than disorder in your mind?
I believe that eating disorder, well, first of all, a related disorder to OCD, which may be sort of a variant on OCD, is body dysmorphia or body dysmorphic disorder, BDD. And I believe that eating disorders, generally speaking, are a subgroup of body dysmorphic disorder. Basically, the person sees an overweight or fat person, and no matter what, even if they're skin and bones, so a, a it's like a misperception, basically. But I mean, it's such a severe misperception that they'll actually starve themselves to death. I mean, about 25% of anorexics die. So we see how severe this is. But it's a very they have a very high degree of belief in their thoughts, like people with BDD often do, basically. So I do not consider myself an eating disorder specialist. I think some of these folks actually need more a controlled environment, need to be more of an inpatient program where they can relearn how to eat and at the same time get treatment for with medication and therapy as well. I believe they're treatable, but the thing is you can't treat everything, and I leave that kind of treatment to people who are more specialized or to programs that particularly focus on eating disorders. But as I say, I do see them as like a subgroup of body dysmorphic disorder.
Okay, so with the body dysmorphic disorder, like let's say their obsession is around that their, nose is unattractive, that they're, so what is the so are you having them say to themselves that this is true?
We work up to that, sure, and along with and I believe medication is very important with these people because their degree of belief can often be much higher than you even see in people with OCD. That it's really it's really up there. Basically, it's near delusional in some people, almost not quite, but way up there. So yeah, we do the same treatment, but with that kind of disorder, you're going to be in for a bit of a longer haul with that, and going to have to be much more patient, and the person themselves is going to have to be much more patient. Sometimes, they have to convince themselves first that they've exhausted other remedies by trying to fix whatever the thing is themselves, or go for surgery or dental work or all kinds of things, and have not found any results. And then sometimes they'll go for therapy,
Hmm.
but that's usually not their first choice. Their first choice is to fix whatever they think is wrong with their appearance.
Do you see it as a doubting disease of sorts? Is that how you
Yeah,
lump it in?
but again, as I say, the degree of belief is so high that it's almost at the outer edges of doubt, you might say.
Okay, so is it like a delusion? There's a delusional character, or
Almost, not quite. If it was delusional, then we're talking about, again, a thought disorder. This is more like OCD, but again, it's the very person very strongly believe they'll argue with you that they don't have what they say they have. If they have what they say they have, and that you're wrong and all, and they'll give you all kinds of evidence for why they're pretty sure it's true.
okay.
I would say, they're like 95% certain that it's so.
What about trichotillomania? Is that I know you treat that. I know you've written about that briefly. Like, what is that a doubting type of disease as well, or
No, not really. It's part of a group of what we call body focused repetitive behaviors, or BFRBs, and we think that these are more. Uh, there's a lot of inputs into them. There can be thought input, that like a person say, well, certain kinds of hairs have to be pulled. There's like a kind of perfectionism to some people's pulling, like a hair is in the wrong place and has to be pulled out, or it has the wrong texture or the wrong feel to it, or it's the wrong color, things like that. But then there's also for many people, it's a big sensory component also, and it's really you have to treat this very comprehensively because there's many inputs. These are much more complicated than they appear. There can be cognitive elements, there can be sensory elements, there can be emotional elements, environmental inputs. There's a whole range of things that you have to take into account when you're designing a treatment for someone. And these things can exist in different proportions to each other. Some people it's more sensory, other people it's more cognitive, and so it's not a one size fits all treatment. It's a treatment that has to be tailored to each person, basically, and that's true of excoriation disorder, what they call skin picking, things like that. So it's a real specialty, and it takes a really a deep understanding of these problems rather than saying, well, it's just a bad habit. That's what a lot of it gets tagged as that a lot, unfortunately. But it can be quite excruciating.
Absolutely, yeah. How about skin picking? Was that kind of lumped in that
Same
same
thing. We
category?
that sort of yeah, same approach, same sort of categorization, and all. And the interesting thing is you see these behaviors in animals also.
Oh yeah.
Uh,
My
in
cat, my cat does that.
Yeah, it's called feline alopecia. It's called where
Hmm.
the skin, not the skin, the fur off their backs. Basically,
Mm.
dogs have something called canine acral lick, where they lick the fur off their paws. Horses do. I ride horses, so I'm around horses quite a bit. Horses have repetitive behaviors like that. They call flank biting. They'll pull out, their own fur, basically. So yeah, these the animals obviously much simpler. There's not really a cognitive element to what animals are doing, but if they're usually kept from doing instinctive behaviors, like if they kept penned up or in restrictive circumstances, very often they're more likely to do that than if they're allowed to, more freedom and the ability to carry out their normal instinctive activities.
Okay, so coming back just once again to this, I want to make sure I get this idea correct in my mind about so you have this obsession, like I could murder someone. And then the first sort of gradient of that is to maybe have them write it 25 days, 25 times a day, write that over and over again. But you're writing like a lesser degree of it, right? Like
Yeah,
I
and
I
that would only be one assignment out of several.
that would be, yeah,
Basically. We,
one
we
out
don't
of
just give
several.
one assignment, we give like an array of things so that they're always working and hitting it from different angles through
Right.
different
Okay.
channels.
So the first time when they're writing that out many times, it's not I could murder somebody. It would be less
Right.
extreme, right?
Yeah.
Like there are some people that murder people.
Yeah. Yeah. We would start with something, a little bit provocative, but a little more on the neutral side that doesn't is not directly about them, more general.
Okay. And then the story, the two-page composition, is that, let's say you start that, is that about them or it's about in general people murdering
It
other
would
people?
again, it would probably be we work from the general to the specific.
And then so there's articles that you would have them read as well, and maybe
Yeah,
videos. And
absolutely.
so you surround them from like all different sides with these different modalities. Are there other ones that you haven't talked about that you will often do?
Again, as I say, we go places, we do activities, we say things, we carry out actions, we write, we listen. It could be again, there's no one size fits all for OCD, so it has to be, tailored to that person basically and their specific OCD and what they need, essentially. So like the same principles are at work in each people's treatment, but the balance of what they do might look different from one person to the next.
Awesome. Well, as you think about OCD and what we've talked about today, are there other things that we haven't touched upon that you feel like you'd want to sort of impart to my audience before we wrap it up?
No, I think we've hit a lot of the main points here of all this. My main message always is just that OCD, as opposed to some other kinds of issues, is treatable. There's always hope for people if they're, willing to do the work and get the right kind of treatment. And I think that's, always people want to know that because they need the hope basically, and they need that to motivate themselves to the belief that yes, I can do this, I can get better and all. And I always try to make that clear, even from the first session with my patients. I say, of all the things that you could have, this is something you really can recover from. So, and if you just do the work, then you're going to get the results.
So you're not
They,
you're not sitting in the doubt from session one with them, like a little bit of reassurance in the first one.
right, but it's more general. It's not about their specific topic. Uh,
Right.
for the
Okay.
most part, it's just about why they're there at all and what we can do for them and what they can do for themselves and all. And that I that I do believe that people have it in them to recover. They just have to kind of find that within themselves and be at the right point where they say, you know what, I've had it. Enough is enough. I'll do whatever I have to do. I don't care anymore. I have people who come in and say anything that you could ask me to do couldn't be any worse than what I go through on a daily basis. And I
Oh
know
yeah.
these people are going to recover with that
Oh,
kind of attitude.
okay. That's good.
So
So since coming on my podcast the first time, has anyone told you they listened to the episode and sought your
um, I don't. The people don't always tell me everything they watch and listen. So I don't know. Some people say they've seen me online, but they don't generally go into detail
okay.
too much. So I haven't been able to really keep track of that. Usually we have so much to do in a session that I don't really have too much time to indulge myself.
Are you still seeing clients at this point?
Oh, absolutely.
Okay.
Yeah, I
And
I see about 3 dozen people a week.
okay. And then you have other people that work for you as well. Your wife is an OCD expert, huh?
I have people who work with me. I don't have anybody who works for me. We have sort of a cooperative,
Okay.
basically. So we
Yeah.
work in the same place, but nobody's the boss
Oh,
or tells
well,
anybody what to do. I never wanted to do that. I never wanted to be in that position, and I didn't want to work for anybody else. So this was kind of a good compromise.
very cool. Okay. So what's the main way to get a hold of you? Like your website would be the best?
Yeah, that has all the information on it, how to contact us. It's got all my articles from the past and all that. And one other thing I just want to throw in there, just at this moment here, if I can. Another thing we've been in OCD that we've been turning our attention to lately is working with people who are on the autism spectrum.
Mm,
Autistic people also can have OCD, and there can be a fairly high percentage of people on the autism spectrum with OCD. And that, my message is that they are treatable, and they're great to work with, and there's a lot of help and hope for them. Unfortunately, there's a lot of therapists who believe they can't do it or that these folks can't be treated, but that's
yes.
really not true. That they're, and I think there's a growing awareness in the autism community of OCD and the fact that it's the features of OCD are different from features of autism.
Yeah. So give me like one example of like someone who has autism that also has OCD. And
Well,
is
they
it
they
just
can have pretty much the same topics as people with as people who have OCD who aren't autistic,
mm,
basically. So it doesn't look that much different, and we can sort of sort that out because there's some things that are more part of the autism that the person wouldn't want to give up or isn't interested in giving up, and it's really an essential part of them. And we don't try to force people to change that way. I don't believe in coercive therapy and everything. But if they say there's certain other things that bother me that I want to get under control, then I say fine, let's work on it. Let's do that. And all these other things that other people are telling you got to change. And I say that's up to you. I mean, I can sometimes convince people why certain features of their autism may be getting in their way, and leave it up to them to decide what they want to do about it. But I respect everybody's right to be themselves essentially in any way that they choose.
mhm. Very good. Well, thank you so much for coming on, Dr.
Yeah,
Penzel. I appreciate
thanks for
you
having
and
me.
appreciate your expertise and your yeah, really grateful for you sharing your expertise with the audience that listens to this. So appreciate
Oh,
you.
my pleasure. My pleasure. The more information we get out there, and the more people we can get to, I think the more wellness is going to be in general.
Well, I'm sure this is going to help some people, and there's going to be a ripple
Hope
effect
so.
as well, which is what I get excited about. So,
No, it's good. It's a good thing you're doing, and I think educating people is of tremendous value. So I think that's great. Keep doing it.
all right, thank you, appreciate you. We'll leave
All
it
right.
there.
Take care. Have a good day.